Hello, my name is Raven Peterson. Today I'll be conducting a lung and thorax health assessment. To start this, I'm going to ask my patient for her permission to record this and post it online for a school assignment. Do I have your permission?
Yes.
Thank you. Before we get started, I'm just going to say that I'm going to do an anterior assessment and then posterior assessment just because of camera angles. I don't have anybody to hold the camera. I wouldn't normally do this in the clinic. So to start, I'm just going to start by inspecting the chest wall. What I'm looking for is any deformities in the chest wall. I'm looking for breathing patterns, the effort of breathing, rate of breathing, chest wall expansion, looking for symmetry there. I'm looking for any use of accessory muscles or diaphragmatic breathing. She does not appear to be in any acute respiratory distress. Also with inspection, I'm going to be looking for AP ratio, which is anterior posterior chest wall ratio to her lateral chest wall. And to do this, it'll just be a rough measurement. I just have a piece of paper right here. I will have her lift her arm and then just get a rough measurement of the lateral side of her chest, and then I'll measure it to her anterior chest and posterior chest, and the ratio should be approximately 1 to 2, and it is on her. A ratio of any other ratio like 1 to 1 would indicate some sort of barreling of the chest. So after inspection of the chest wall, I'll move on to palpation, and with palpation, I'm feeling for any tenderness, and on the anterior chest, specifically feeling for costal chondral tenderness, which is tenderness where the cartilage and ribs connect on the anterior chest to connect those floating ribs to the sternum. Was there any tenderness on that palpation? Good. After palpation of the chest wall, I'll move on to percussion. And with percussing, I'm going to be putting my non-dominant hand on the patient. And with my dominant hand, I'm going to use my middle finger to strike the middle finger on my non-dominant hand placed on the patient. And when I do that, there should be a percussing sound in the lung cavity. And what I'm listening for are tympanic sounds, resonant sounds, and noting any dullness I may hear. No dullness. Anterior chest is a little more difficult to percuss just because of the breast tissue in male and female patients. And you're just percussing for the border of the lung tissue. Following the percussion of the anterior chest, I will move on to auscultating. And with auscultation, I'm going to start with listening for the apices of the lungs or the very top, the peaks of the lungs. And this can be heard either above or below the clavicle, depending on the anatomy of the patient. Take a big deep breath for me. And then I'll move on to auscultating all fields of the lungs. And while I'm auscultating, I'm just moving in a ladder pattern, trying to put the stethoscope on each side, the same spot on each side. So I heard vesicular breath sounds bilaterally, left and right lungs. I also heard, or I did not hear any adventitious breath sounds like crackles, wheezing, rails, or pleural friction rubs. So that concludes the anterior chest assessment. Next, I'm going to have my patient turn around, and we will conduct the posterior assessment. So for the posterior assessment, again, I'm just going to start by inspecting. What I'm looking for is chest expansion, rate of breathing, effort of breathing, any accessory muscle use, and diaphragmatic breathing, which I do not see a case in her. So after inspection, I'll move on to palpating. With palpation, just feeling for any tenderness in the chest wall. After palpating, I will move on to tactile fremitus, which I'm placing the ulnar aspect of my palm on the chest wall, and when I place it on the chest wall, I'll have the patient say 99.
99, 99, 99, 99, 99, 99.
And again, just moving in that ladder fashion so I can compare each side to each other. And with that, with the tactile fremitus, there's a vibration caused when she says 99, and I can feel that on my hand. And it should be symmetrical on both sides. And I forgot to do the tactile fremitus on the anterior aspect of the chest. So just to demonstrate with my patient here, I would do that again, have the patient say 99.
99, 99, 99, 99, 99, 99.
Good. I did, again, symmetric tactile fremitus on the anterior aspect. So moving on from there, I am going to percuss the chest wall. And on percussion, again, using the same technique, and I am going to avoid the scapula and placing my non-dominant middle finger in between her ribs. If I percuss on a rib, it will appear dull. So just placing the intercostal spaces. And again, I'm just listening for tympanic sounds and no dullness, and I am percussing for the borders of her lung tissue. Following that, I will do the respiratory excursion test. And on the respiratory excursion test, I'm going to be placing one hand on each side of the rib cage and having my patient take a big deep breath in. And when she takes a big deep breath in, my hand should separate on her chest wall expansion, and it should be symmetric left and right. So I'll get my hands in place with my thumbs just on the left and right side of the spine, and then have my patient take a big deep breath in. Good, so you can see there is chest wall expansion, and it is symmetric on both sides. The next test I'm going to be doing is diaphragmatic excursion, and on this it'll be a percussion test. And what I'm going to do is lift the patient's shirt, and the diaphragmatic excursion test is measuring the distance traveled by the diaphragm on inhalation and exhalation. And so on inhalation, her diaphragm is going to be pulling down, opening her lungs. And when I have my patient take a big deep breath in, I'm just going to percuss. I'll hear tympanic sounds, and when I first meet dullness, I will mark that site, and I will do that on the left and right side. So I'm going to have my patient take a big deep breath in and hold it. Percussing until I meet dullness. Then I'm going to mark that spot. And then I'm going to have my patient take a big deep breath in and then exhale and then hold the exhalation. And I'm going to do that same percuss and meet dullness and mark the spot. So take a big deep breath in, exhale, and there's my dullness there, marking that spot. And then I will measure the distance the diaphragm traveled, approximately 3 centimeters on her, which is normal. Posterior chest wall after percussion, I'm going to move on to auscultating. And again, listening for the apices of the lungs. Take a big deep breath when you feel my stethoscope. Now, on the posterior chest wall, you shouldn't be able to hear the apices as well as you can on the anterior chest wall, but you should be able to hear the lower lobes better on the posterior chest wall. So on auscultating, I will again move in the ladder fashion, avoiding her scapula. So each time you feel my stethoscope, take a big deep breath in. As I go down, I am just listening for clear breath sounds and symmetric breath sounds. And then from here, I'm going to auscultate the lateral aspects of the chest wall, both left and right side. Take a big deep breath in. Big deep breath. On the right side, on the right lateral aspect of the chest wall, that's where you can best hear the right middle lobe. And last, I'm going to mention on inspection, you also want to inspect the patient for color in their lips and clubbing and color in their fingertips, which is just quickly done on inspection and can reveal some significant respiratory issues. And last, I'm going to also do a special test called a bronchophony test. And with this, I'm going to have my patient say 99 again. And while she's saying 99, I'm going to be listening to her lung fields with my stethoscope. And when she says 99, it should be a muffled sound when I'm listening to my stethoscope. If she has any consolidation in her lungs, the 99 sound will be more clear, like I'm listening to it without a stethoscope, and that would be concerning. So I'm going to have my patient say 99 when she feels my stethoscope.
99, 99, 99, 99, 99, 99.
Good. So yeah, I heard muffled 99 sounds and all lung fields there. And again, just going to mention that all her breath sounds were vesicular. There were no adventitious breath sounds, anterior or posterior, no wheezing, rails, crackles, friction rubs, and they were vesicular. On the anterior aspect of the chest, you can hear bronchial and tracheal sounds, but not so much in the posterior. And that concludes my lung and thorax assessment. Thank you.